So what I see a lot out on the boards when people are talking is like, oh, we went through genetic testing. And I think that they're really thinking of having the tumor tested.
Yeah.
Okay.
Yeah. A lot of times, like, when I meet with someone who's referred to me, we'll talk about genetic testing and they'll say, oh, I already had that. And I'm like, oh, you did? Where? They're like, well, the oncologist told me they were going to do some genetic testing. I'm like, on the tumor, right? Because they do some genetic testing on the tumor because one, it helps define what kind of tumor it is, and two, they use a lot of that information actually also for prognosis. Like, is it a favorable prognosis? Is it a poor prognosis? And there are certain things that in the tumor, when you do the molecular testing or gene testing on the tumor, that tells you what's the best way to treat it. What sort of chemo should we go after this with, chemo and radiation? Though it can be, as you say, very confusing, and sometimes that type of testing, like I said, can give us clues as to the other type of testing, the germline testing, the syndromic or hereditary testing. But what's going on in the tumor is not always what's representative of what's going on in the rest of the body.
Welcome to the webinar. This is a discussion about cancer predisposition, particularly in Wilms tumor. I'm Robin Spoon, the CEO of Elevate. Our mission is to provide education to those impacted by pediatric cancer. Joining me today is our members of the Elevate Wilms work group. And so we have Erin Abbott, Courtney Comer, and Miriam Weiss, who are all on the planning committee for this webinar, for this education piece. And then in addition to that, we have Joyce Turner joining us. And we are incredibly grateful to Joyce for taking time out of today. She's the director of Cancer Genetics Program at Children's National Hospital. Our group has really enjoyed learning from Joyce, and so we thought we would share some of the things we've had a chance to learn from Joyce here with others who've been impacted, particularly by pediatric Wilms tumors. So with that, I think we'll go ahead and just get started and let Joyce share her slides and start a discussion around predisposition syndromes for Wilms tumor.
Well, thank you so much, Robin, and the team here for having me join you today. As Robin mentioned, I am a genetic counselor at Children's National Hospital in Washington, D.C., where I am the director of the Cancer Genetics Program. I came to Children's about back in 2008, so I've been here quite a while, and in 2012 started the Cancer Genetics Program. And over the course of my time at Children's, I've been able to work alongside one of the oncologists, Dr. Jeffrey Dome, who is a world-renowned oncologist and knows quite a bit about Wilms tumor. And so with that, coupled with the explosion of genetic technology, as well as our understanding of Wilms tumor genetics, we have worked together to write several chapters about Wilms tumor, as well as publish a number of articles. And so with that, I will share what I've learned over the course of time. And so today, I've been asked to talk to you a little bit about what is a genetic counselor and why people will go forward and have genetic testing. Just to even out the playing field, we'll discuss some basic genetic terms so that we can understand what sort of genetic testing can be done. We'll also go over what the difference is. You might have heard the terms germline and somatic, and so we can define those terms and talk a little bit about the differences between germline genetic testing and somatic genetic testing. And how do we really differentiate? What are some of the red flags that help to differentiate those individuals who might have a genetic predisposition to Wilms tumor from those who have a Wilms tumor that occurred sporadically and not associated with a syndrome? And we will also wrap up with a case example and the different types of technologies or tests that we can use to do some genetic testing and future directions. And of course, I want during the course of these slideshow or this talk, we can interject some stories from some of our board members. Erin and Courtney will share some stories as well. Okay, so what is genetic counseling? This is a question that I get all the time when people ask me what I do, and I say I'm a genetic counselor. And so genetic counseling, basically I did an undergraduate in biology and went on to get a master's in medical genetics that focused specifically on genetic counseling. And when I was finished with that, I had to be boarded. I had to take a certain test to become certified. And after that, I have since become a licensed genetic counselor. There are different types of genetic counselors. Some are prenatal, some are specialized in adult cancer. I specialize in pediatric cancer genetics. And so when I meet with a family, when a patient is referred to me, there are a number of different things that I do. I will obviously review their medical history from their medical records. And when I meet with them, I will ask targeted questions pertaining to things that I couldn't find in their medical records, as well as draw out their medical history to see what clues I can find to help me decide whether or not this is more likely to be a genetic syndrome versus a sporadic occurrence of, let's say, a Wilms tumor. And so there are certain programs and things that I take into account when I'm looking for people who are at risk in the family. I will meet with the family and come up with a differential diagnosis based on the information that's presented to me and explain that to the family, educate them about what we could potentially test for and how we go about doing that testing, to explore what are the risks of doing this testing, as well as the benefits. How is it going to be helpful to you moving forward? We discuss outcomes of that genetic testing, including a positive result, a normal result, or even something called a variant of unclear significance, where we find a change in a gene, but we don't know what that means. I also will discuss with the family how to go about doing the testing, whether that be on blood, saliva, the tumor itself, or even the need sometimes to do a genetic testing on DNA taken from a skin biopsy. Obviously, once the genetic testing results come back, I will sit and meet with the family to discuss those results and talk about whatever surveillance is recommended based on what we find. So while an individual might have been diagnosed with a Wilms tumor, are there other syndromes or other medical problems we need to be on the lookout for? So if something else were to develop, we're identifying that at an early stage when it's most easily treated or intervention is optimal. And of course, I work very closely with an oncologist as well as other medical providers to help facilitate that tumor surveillance over the course of time. So while I might meet with someone to diagnose them, I usually, for those people who test positive for a genetic syndrome, we see them back yearly or however frequently the protocol dictates for monitoring purposes. And so with regard to why someone would want to do some genetic testing, about 20% or so of individuals or children who develop cancer are thought to have an underlying genetic cause or syndrome associated with that tumor. And so 20% of the time it's syndromic, 80% of the time it's not. So trying to differentiate people who have maybe a syndrome from those who don't. And of course, if so, we want to be able to screen those individuals for the additional cancers or medical problems for which they're at risk. We also want to see if, well, we have one person in a family that's affected. Are there other family members that we don't know about yet that we need to test other family members to see if they need surveillance as well? And nowadays, a lot of genetic testing is also being done for chemotherapeutic reasons as well. Is there a certain gene change or that a person has in their entire body? Or is there a certain gene change someone has in their tumor that would say, hey, we should use this specific chemotherapeutic agent because it works better in that situation? And so there are a lot of different types of testing that one can do in terms of genetic testing. Oftentimes I'll get a call that says, I was told by my pediatrician to call you for the genetic test. Well, there's not one genetic test. We can do single gene testing where we're just looking at the spelling of a single gene. We can do panel testing where we're doing 10, 20, 30, 100 genes at a time. We can look at the genetics of a tumor. We can do something called methylation studies, which I'll get into a little bit, as well as chromosomal studies, which I'll get into a little bit. And I think since we kind of prefaced everything before we kind of jump into what all these different terms mean, it might be a good time to just pause and hear from Erin. So I'm
Thanks,
going to stop, or do you want me to stop sharing, or do you want to?
Sure, that'd be great. We can, or let's leave it. That's okay.
Okay, sure.
My name is Erin, and my son Wyatt was diagnosed at 8 months old with bilateral Wilms tumor, stage 5. And our journey to diagnosis was a little bit unconventional. That started back at birth and was very interdisciplinary for the result in his WT1 predisposition. He was born at 39 weeks, big boy, 10 pounds, 10 ounces, with undescended testicles. Should have been our first clue there. The protocol at that point was that we were going to wait till he was 4 months old in hopes that these would descend on their own. One of our other clues should have been that they were unpalatable, meaning we couldn't feel them kind of above that scrotum area. At 4 months, we went to the urologist where we kind of did a once over on his body. We did not think he had an overgrowth syndrome at that point. His tongue wasn't enlarged. There wasn't kind of a difference between the sides of his body. However, we couldn't find those testicles. So from here, we did some thorough blood evaluation and learned that he had low testosterone and low LH. And the goal here was really to find out if his testicles were somewhere. So we moved over to the endocrinologist, who decided that to find these, we were going to do some HCG injections, some human growth hormone injections, to understand if there was an opportunity for that testosterone level to increase and if there were testicles there to hold on to that testosterone. We were in a great position where we did show robust levels and a small background. Babies are typically born with high sex hormones, and then they taper off before elevating again in puberty. So we knew that his testicles were holding on to this testosterone, and now we were in an exploratory phase where we could jump into an ultrasound. And it was this ultrasound where we found that his kidneys looked a little bit different. They were described to us as cystic, resulting in us moving over to the nephrologist. And this appointment was a shock to my husband and I. It was hard that they diagnosed him with stage 1 kidney disease and thought he had some sort of polycystic kidney disease going on that we wanted to find genetic testing for. So that was the goal of our genetic testing originally: figure out if he had polycystic, dominant, or recessive cysts in his kidneys. And it was here that we got our results back that he did not have a gene that was related to any cystic syndrome. It was WT1. We were encouraged to jump onto the 3-month surveillance scans. And the very next day, I was able to get in for an ultrasound where we found his first tumor. He resulted in 4 masses, 1 being a Wilms tumor and 3 actually being nephrogenic breasts that were still treated the same way as the Wilms. And we were considered a bilateral patient, having those surgically removed and going on with chemo treatments as well. He's 16 months now, 3 months off of treatment. He had scans this week that looked great. So we are going to keep doing our 3-month surveillance scans. But the genetic testing really led us to an early diagnosis that preserved a ton of kidney with his nephron sparing surgery. And we feel really grateful to be able to have multiple disciplines within the hospital that were on board with this genetic testing. Joyce, I'll let you take it back over from here.
Thank you so much for sharing your story, and it does kind of exemplify the odyssey that many of our families take in trying to figure out what's going on. Um, Oftentimes when we see patients in genetics, they have quite the extensive medical record of all the different providers that they've already seen before they get to us. So, okay, so let's talk about some terms. Like I said, let's make sure everyone understands what I'm talking about here. So there are a number of different techniques or tests that one can do. But before we kind of jump into those different tests, let's just to say what this is. This is a picture of a boy and his chromosomes. And so you can see that we each have 2 pairs of chromosomes. We have 23 pairs of chromosomes. They're just numbered from biggest to smallest, not too complex. And it goes through 1 through 22. And then if you're a male, you have 1 X, and if you're and 1 Y, and if you're a female, you have 2 X chromosomes. And so all along the lengths of our chromosomes are our genes. And so because we have 2 of every chromosome, one we hear it from mom and one we hear it from dad, we also have 2 of every gene, except for those genes on the X and Y chromosomes in males. They only have 1 copy of each gene on those chromosomes. And so if you look at your chromosomes, it's basically tightly coiled DNA, kind of like a slinky, for those of you who are familiar with slinkies. And if you untwist that slinky, you can see that that's where our genes lie all along the lengths of those of our chromosomes. And if you untwist it even more, you can actually see the DNA itself. And it looks like a twisted ladder, with the rungs of the ladder being the actual code. And so we have A, C, T, and G, which stand for adenine, guanine, thymine, and cytosine. And when those different letters come together, it spells something, okay? And we refer to those different letters as either nucleotides or base pairs. A's match with T's, C's match with G's. So it's a double helix, so you have those letters on either side of the helix to make up the rungs of the ladder. Okay, and so you can think of your genes much like a recipe, our recipe that tells our body how to make, let's say, a batch of cookies. Our genes tell our bodies how to make a protein. So how do we go from the actual gene to a protein? And this is kind of a complicated slide, but don't read too much into it. Basically, you have your DNA strand, and your DNA strand is made up of coding regions known as exons and non-coding regions known as introns. And those introns we're learning are much more important than we once thought. It used to be thought of as junk DNA, not so much anymore. And so when we read the gene, when we're making a protein, basically the first step is transcribing that DNA and to make a primary RNA transcript. And so basically what happens in that transcription is all of those T's are replaced with U's, or uracil, and they get little caps on the end of the RNA transcript to protect it. And then all of those introns are actually removed. They're spliced out, and all of the coding material, all the exons are squished together. So basically you can think of this as like a word in a sentence, like genetic counseling is so important. And then if it goes through transcription, you're going to change all those T's in the sentence to U's. And then it has one more step where all of the spaces between the words are removed. So you just have the code itself. Okay. And so you're left with, I should say that just the code is what we refer to as mRNA, or messenger RNA. And it kind of looks, you can think of like a xylophone or a piano. And each of those, every 3 letters or every 3 keys of that xylophone or the piano codes for a particular amino acid. So you have these little structures called tRNAs or transfer RNAs, and they are specific to those codons. It says, okay, I need a phenylalanine amino acid, and it brings the phenylalanine to the code. And it goes along every 3 letters, codes for a very particular amino acid. And as you can see, what you end up with is like beads on a string, very much like Mardi Gras beads, right? That's the final product, and it'll fold upon itself to make the protein. And that protein has a very specific structure in order to do its job. And so you can imagine that if there is a, let's say, a mutation in an exon, then it could cause, let's say, that transcription or that reading of that gene, let's say that the mutations could say, this is where I want to stop. And so that transcription could end early. And your result is a shortened messenger RNA, which therefore might not even be able to produce a protein product or a malformed product. Or let's say you could have a mutation in an intron, and that intron is no longer removed, and all that extra genetic material is left in the protein, which therefore it can't function or form the way it's supposed to. Or you could have a simple spelling error. You know, one of your C's is changed to an A, and therefore it doesn't bring the correct amino acid to when it's developing, making that protein. And therefore that very special structure of the protein can't form correctly and therefore do its job correctly. And as a result, we have all these different syndromes that we can develop. I've also been asked a lot, well, what is germline versus somatic, and what is germline mutation testing versus somatic mutation testing? And so you can think of a germline mutation as anything that's in a gamete. So a mutation that's found in a sperm or an egg, because that sperm that, let's say, has the mutation will go into the developing embryo, help to form that embryo. And that mutation is going to be in all the cells of the body and all the cells of the resulting individual. And so when we do genetic testing on, let's say, blood or saliva or cheek swab, those samples are thought to be representative of everything we see in the body or throughout the body. So we're looking for changes in the DNA from those samples. But when we're talking about somatic mutations, that somatic change or gene change is not present in the gametes, it's not present in the sperm, it's not present in the egg. It could potentially be acquired by chance alone in the developing embryo, or it could be acquired, you know, in a developing child or even as an adult. And so that mutation is only in that one cell, but then that cell divides. And if it's a mutation that affects the control of the cell cycle, then that cell cycle is no longer well controlled and it can grow out of control, which is what a tumor is. So that mutation is really localized. It's only in that particular area. It's not something that's in all the cells of the body, and it's not something that's going to be in potential risk to offspring. It's just, let's say, in the kidney. And so when we do genetic somatic testing, we're really only testing the tumor or the affected tissue. We're not testing all the cells in the body. Sometimes we can get clues from that tissue. So we might, let's say, if we were to do molecular testing on a Wilms tumor and we find a WT1 mutation in the Wilms tumor itself, it might say, hey, since we found this, we really should test, blood, we should test cheek swab in order to see if it's also in the rest of the body. And so our genes follow what's called, or our cancer genes anyway, are thought to follow what's called a two-hit hypothesis. And so trying to differentiate something that's inheritable or a syndrome versus just sporadic, we each have, in a normal cell, in a normal, let's say, kidney cell, over the course of time, just by chance alone, we can acquire a mutation, let's say, in the WT1 gene. But since we have two copies of every gene, we still have a working copy of a WT1 gene, and therefore it can go on functioning and doing its job appropriately. But over the course of time, we could acquire a second hit to the other copy, and therefore in that one cell there's no longer a functioning copy of that WT1 gene, and therefore that one gene can become 2 and grow out of control, become 4, become 8, and all of a sudden we now have a tumor, just because that one gene and that one cell was knocked out without a function. So that would be more of a sporadic occurrence, an isolated event. It started in one cell of the kidney. But if you are born with a mutation in the WT1 gene and you already have one mutation or one copy knocked out, and then over the course of time we acquire a second hit, that particular tumor is going to happen or is going to occur we would expect that to occur at an earlier age. The average age of a Wilms tumor is roughly around 2. So if we're seeing this earlier than 2, that would be a red flag. What's going on that caused this to develop so early? So that's kind of how we think about cancer genes in general. And then some of the tools that I use to try and distinguish between something that's genetic or hereditary versus something that occurs sporadically. I take a family history. Do we see generation after generation of people who are affected with a Wilms tumor, or do we see a Wilms tumor co-occurring in a family where we see other tumors that are commonly seen within a syndrome itself? So I kind of I take a very detailed family history and look for those sort of red flags. Also, is it bilateral? Is it in both kidneys? It would be very unlikely for something to be not hereditary when you have both kidneys affected at a very early age, or if you're seeing multiple lesions in both kidneys at an early age, or you have one kidney that's affected, but multiple lesions, or lesions being Wilms tumors or nephrogenic rests, which are Wilms tumor precursors. So we're looking for that. So I'm looking not only at the family history, but I'm looking at the pathology, I'm looking at the radiology results. And then we can also get some information from the pathology itself. We know that certain types of, let's say, these Wilms tumor precursors where we tend to see stromal cells, those types of cells are more commonly seen in individuals that have a WT1 mutation versus when we see more, epithelial cells, we tend to see those more commonly nephrogenic rests in those who have Beckwith-Wiedemann syndrome. And then, of course, as I said before, is this occurring at an age that's atypical for the general population? Are we seeing it at 6 months? Are we seeing it at a year versus when most people who don't have a syndrome inherit it? Other things that we're looking for include other medical findings. Is it just bilateral or even unilateral unifocal Wilms tumor, or are there other things that we can find on medical exam? And I work very closely with geneticists and doctors that help me find these things. I personally don't do the physical exams. But is this someone who was born that has a larger than average tongue size? Usually these individuals might have Beckwith-Wiedemann syndrome, which can co-occur with Wilms tumor. Sometimes they have it, sometimes they don't, but we need to ask the questions and we need to look. Is there someone who might have one limb or one side of the body or one organ bigger than the other side? Do we see even subtle differences? Do we see any ear creases that are not typical? We know that individuals with Beckwith-Wiedemann syndrome can sometimes have creases on the ear. So we're going to look really, really carefully for little subtle signs of these differences. Does our patient have any sort of brain differences? Do they have any sort of cognitive or developmental impairments? So those are all the different clues we use to try and figure out what's going on with the individual. And so in 2022, Dr. Dome and I published an article which kind of looked at the decision tree of what we can do to try and differentiate those people who have Wilms tumor because of a syndrome versus those who just have a sporadic occurrence. And so anything that's bilateral, anything that's multifocal, even if it's just in one kidney, anything where we see multiple nephrogenic rests or what we call nephroblastomatosis, that's like a knee-jerk response. Those people should be referred immediately. What becomes less clear is those individuals who have a Wilms tumor, let's say in one kidney, and they only have one lesion. does that individual have a genetic syndrome? And so again, we need to go through all those clinical findings to check off to see, is there anything abnormal about the pregnancy? Is there, did they have extra fluid around the baby when they were pregnant? Was the placenta bigger than it should have been? And, was the birth weight grossly, was it a 13-pound baby? Were there were genital anomalies identified? Were there undescended testes? So anything else, we would say refer for genetic counseling and testing. If the answer to that is no, was there anything on the pathology? Was there stromal predominant? What was their epithelial predominant cells? If the answer is yes, they should be referred. If the answer is no, then you say, okay, well, is there anything in the family history that's concerning, where there's like early onset breast cancer, where there was their thyroid cancer in childhood? Do we have individuals in the family who are related? Are they first cousins? Are there any other family members with multiple congenital anomalies? Anything, we have a very low threshold for referral, but anything out of ordinary, refer. And at the end of the day, if the answer to all those questions are unilateral, unifocal, there's nothing else in the family history, there's no other clinical findings, then the chance that we're going to find a genetic syndrome is pretty low. That doesn't mean that they couldn't come and talk to us and we can talk about it or even do testing. But the chance of identifying a problem is going to be probably not very high. And it's also a question we have to, be realistic, whether or not your insurance company is going to cover that type of testing if there's no reason medically that we can find to give weight to support that testing. Because, the letters I write after a visit are usually like 3 or 4 pages long, if not longer, justifying why this person should have genetic testing. So those are kind of all of the different types of things that I think about every time I meet with an individual who's referred to me for Wilms tumor. And with that said, I'm going to turn the tables over to Courtney, who has another story and experience to share with us.
Thank you. My name is Courtney Comer. I'm a nurse and a mom of 5 children. 3 of my children are diagnosed with Perlman syndrome, a rare cancer predisposition syndrome. Children with Perlman syndrome have between a 64 to 70% chance of developing a Wilms tumor by age 8. It would take 3 children's hospitals, 2 cancer diagnoses, and many years before my children were ultimately diagnosed with this syndrome. So what happened? When starting a family, I visited a genetic counselor because I was concerned about the amount of relatives diagnosed with cancer. You've won the genetic lottery, my genetic counselor told me when she called to say that all my panels were negative for cancer-causing genes. My second child had airway issues, unusual facial features, and it took him longer than normal to reach developmental milestones. The neurologist assured me he was just an immature walker. In 2019, at 3 years old, my daughter was diagnosed with a Wilms tumor in one of her kidneys. Again, I requested genetic testing. She had been a gigantic baby with an enormous head. She had been complaining about leg pain, and I also remember that my midwife told me that Ella had the largest placenta she had ever seen. I presented the oncology fellow with her growth chart and asked for testing for overgrowth syndromes because some of them are known to cause Wilms tumor. The oncology fellow told me, "Your daughter is just obese." Genetics did consult, but declined to perform any testing. It would take 2 more years and 3 different hospital genetic consults to finally get testing. My son was tested first. While we were waiting for his results, my daughter relapsed. This time, cancer filled her body, all the way from her liver to her rectum. Shortly after that, my son's genetic testing resulted in the patient portal. He has Perlman syndrome. My husband and I were found to be carriers, and no, we are not related. It turns out that 3 of our 5 children inherited both copies of our defective genes. The oncologist cried when he called and told me the news. My story illustrates the barriers to accessing genetic testing. I believe that my daughter's first Wilms tumor diagnosis was a missed opportunity to screen for cancer-causing syndromes.
Thank you, Courtney, for sharing your story. It's very heartfelt. It is something that unfortunately is not the first time I've heard, and the odyssey that people go through to have an explanation for what's occurring in a family. Just this week, I had a similar situation arise where it took, 3 people and several cancer diagnoses before they were actually referred to me. And so I think it emphasizes our need to educate our doctors. And one of the things that we're really pushing for in our department is having the oncologists rotate through the cancer genetics clinic. Not just one day, which is where it is right now, but multiple days. So they have that. They might not know everything, but they keep that in the back of their mind when they are seeing a patient in front of them. And so it just highlights where we've been in terms of educating our doctors and other medical professionals, like our endocrinologists or our urologists, and where we need to go moving forward. So thank you both for those very important stories that we can learn from. Okay, so with regard to genetic testing, there are multiple syndromes now that we've learned over the years that can put one at risk for a Wilms tumor. And I'm not going to go through all of these. I think they're on this 3-page slide of different syndromes. There are probably 25 to 30 different conditions that we know of today. Some of them have associated features and some of them do not. And so we have to keep in mind all these different features and ask all those questions when we're meeting with our patients so that we can get the clues that I was talking about to guide our testing. And so I want to kind of go over a case example of a patient that was referred to me and talk a little bit about the different types of testing that we can do to try and come up with an answer. Because like I said, there's not a one test fits all approach. It's actually multiple tests that can be done. And so this particular case, an individual was referred to me at 3 years of age. The individual was born full term. It was an uncomplicated pregnancy and delivery, normal weight, normal length, normal developmental milestones, completely asymptomatic in terms of pain, lethargy, or fatigue, nothing. Normal, healthy, active 3-year-old child. But mom and dad noticed that one side of the abdomen was becoming more protuberant or more prominent over a very short period of time, and they went and saw the doctor. The doctor felt it, and it felt harder than it should. And so the doctor ordered imaging, which showed bilateral renal masses. And obviously referred to oncology and received upfront chemotherapy, and then ultimately went for partial nephrectomies where they removed parts of the tumors that were affected. And so at this point, the child was referred to us for further evaluation, primarily because of the bilateral nature of the disease. And so actually the tumor surgery, the partial nephrectomies was done at an outside institution. So I actually only have partial records, but I was told that the pathology showed bilateral Wilms and there was favorable histology. They'd also done some somatic testing, so gene testing on the tumor itself, and they found a change in a gene called the GNAS gene. Now, most of the time that gene can be altered, but is most commonly found in a tumor as opposed to all the cells of the body. When we see a mutation in the GNAS gene that's syndromic, it usually is not present. It's only what we call a mosaic condition, where it's acquired sometime during embryogenesis. And so a portion of the cells of the body have the gene change and a portion do not. So I kept this in the back of my mind. It's usually not associated with a Wilms tumor per se in the syndrome itself. And I also saw that there was what's called a variant allele frequency, or VAF, of 33%. Now, normally, if it was germline and that gene was present in all the cells of the body, it would be more closer to 50%, right? It's going to be in half of our genes. This was a little bit lower and less than what I thought it should be for it to be a syndrome. So I did keep that in the back of my mind. We also found there were a number of variants of unclear significance, meaning that they found a change in a gene, but they really just didn't know what to do with it. Not all changes in genes are bad. Some of it is merely variation, just like we have different color hair, different color eyes. We have some variation in our genes. It doesn't mean that it's made wrong or it's going to make a protein that's wrong. So I also kept these genes in the back of my mind. And we didn't find any physical differences. There was no family history of concern. This is the family history that I took, sketched out. We see this little girl who was 3 years old. Mom and dad are healthy, nothing on dad's side of the family. There was a grandfather who had prostate cancer at 62, not too early to make me too concerned. This uncle had an arachnoid cyst and some seizures, but really nothing that showed me any red flags from the family history as to guide me in my genetic testing. And so we decided to because we were dealing with bilateral Wilms and nothing else, we took a multi-pronged approach to genetic testing. All those genes that I listed in that table, we basically did a whole panel. We looked at all the genes that we know can predispose to Wilms tumor. And we did sequencing, which basically is the reading of the gene. We're going to go letter by letter by letter to see if we find any changes. The other test we did is something called DNA methylation. Now, this gets a little bit more tricky, but throughout our genetic makeup, there are these little methylation structures, these little things that you see on the screen that say CH3, that's a methyl group. And those methyl groups are situated or located throughout our genetic makeup. And you can think of them as light switches. They tell the genes to be turned on, they tell them to be turned off or active. So these genes are either being transcribed and making into proteins or not being made into proteins. And so we know that on a certain region of the 11th chromosome, there's a region that we say is that is methylated, and the region of that 11th chromosome that comes from mom, some of the genes are turned on and some of the genes are turned off by these methyl groups, whereas in the dad they're turned off versus turned on, so that both copies of mom and dad's inherited 11th chromosome are not turned on both at the same time or turned off. It's different. And so people who have errors in their methylation can develop a condition known as Beckwith-Wiedemann syndrome. So we did blood testing. We did methylation testing on the blood. We also looked at the chromosomes to see, if there were any broken chromosomes, rearranged chromosomes, large chunks of chromosomes that were missing or extra. We also did something called a chromosomal microarray, which we're looking at the same thing, but on a much smaller scale. Is there teeny tiny pieces that are of chromosomal or genetic material that are duplicated or deleted? Is there a segment of DNA that was inserted where it shouldn't be? So we did all of these tests and they all came back normal. So now what? We still have this 3-year-old that had bilateral multifocal kidney disease. There has to be something genetic going on, right? So in recent years, they've been doing, we're going to talk a little bit about somatic testing. They're doing this methylation testing on the tumor itself. The testing we had previously done was on blood, but now they're able to do this methylation testing on the tumor itself. So we took this tumor, we sent it to the lab, they did the methylation testing, and I'm not going to really go into the details of this particular slide. It's kind of complicated, but on the 11th chromosome, we have a region that we call Imprinting Center 1 and Imprinting Center 2, or ISC1, ISC2, and these are the areas that control methylation. And so we looked at these control mechanisms in this individual's kidney, and we found that sure enough, the kidney had erroneous methylation. So we saw that in the maternally inherited copy, they had a gain of methylation where there shouldn't have been. And so some of the genes on the maternal copy were turned off, but the dads were also turned off because they're supposed to be turned off. So there was nothing, like say H19 was not being expressed. And so because of that, this individual is what we refer to as mosaic. So some of the tissues in the body have this methylation error and some of them don't. We know some of them don't because we already did the blood testing. So in the tumor, we know that this individual is we know that this methylation error is at least in the kidneys. It's possible that it could be elsewhere beyond the kidneys, but we're not going to do lots of little samplings, right? So we will follow this individual as though they have Beckwith-Wiedemann syndrome and just expect some of the other problems that might be seen with Beckwith to maybe not manifest because it's a limited area that's affected. All right, so that's what that case showed. We are now learning that we can get clues. Moving forward, we can gain clues in not just DNA testing, but RNA testing. So the same way we can sequence our DNA, we can sequence our RNA. And that RNA testing is tells us something about the function of that gene, if there's a gene change present, right? Because if there's a mutation, let's say in an intron, and that intron is not removed, then when you look at the messenger RNA, it's going to have extra genetic material than it's supposed to. So they look at the RNA and they compare it to the DNA and they can say, hey, we found what the difference is between these two. We can figure out what's going on. So more and more, we're doing RNA and DNA testing. We use a lab whenever we can. We do it at the same time. So they're doing RNA and DNA testing simultaneously. This has helped to decrease the number of variants of unclear significance that have been found. And we're also doing what's called paired germline somatic testing, where right up front, when the person is diagnosed with a cancer or a tumor, we're doing the genetic testing on that tumor. We're also doing genetic testing on either blood or cheek swabs to try and figure out, is there a treatment that's good for this patient? And is this a syndrome that we're dealing with? And that some places are doing that right now, some places are not. I know I am definitely pushing for that in my institution, so we can find things at an earlier stage and we don't have to go through some of the odysseys, diagnostic odysseys that our panelists here have gone through. And so and then the future is gearing towards something called long-read sequencing, which I'm not going to get into today, but suffice it to say that technology basically wraps up a lot of the technologies that I did describe today into one test. So it's much more comprehensive. And so basically, with regard to genetic testing strategies, the first thing on the totem pole is what do I see in front of me? What's in the medical records? What are the physical features? And that's going to guide my genetic testing. We can do testing on blood. We can do testing on cheek swabs. We can do testing on DNA taken from fibroblasts. When we do gene panel testing, we can do methylation studies, as I've described, and that can be in the blood. It can be on the tumor. We can do chromosomal microarrays and karyotypes, where we're looking at the chromosome structures themselves and if there are any missing or extra pieces of genetic information. We can do tumor testing. We can do them both at the same time. And then we can do something nowadays that's called whole exome or whole genome sequencing. And whole exome sequencing is something where we're looking at genes, but only the coding regions or the exons of the gene, with the exception of few like intron boundaries. So it does miss the intron portion of the gene. Whole genome includes the exon and the intron, and that's more so in the research setting at the current time. And those technologies are really used for gene discovery. You know, if you have a whole group of individuals who have unilateral Wilms tumor, you have one tumor, taking that group together, doing exome sequencing, doing genome sequencing to try and decide, is there anything that this group of patients have in common to explain why this is happening? So that's more of the gene discovery. And with that, I will close and open the panel up for discussion and questions.
Thank you so much, Joyce, for all of that. I know every time that, we speak, I learn more about this whole process that is incredibly complicated. Let's just take a couple of minutes here at the end. One thing I want to clear up, because I see this a lot, what the world calls these things, sort of like the lay people out there, is what you're calling these things, technical terms of sort of like germline testing versus somatic testing. What, just to make sure that I have this right. So if we're talking about germline testing, we're really talking about these sort of more genetic predisposition things versus, just to make sure I have this right, this somatic testing is more like what happens inside the tumor itself. Is that correct?
That is absolutely correct. Yep.
So what we hear people out there really saying is genetic testing or genomic sequencing. Is that still correct, or is that like a bad use of those words? Like what do we
genomic sequencing is really not the same as genetic. I mean, it's one type of genetic testing, right?
Okay.
And so sequencing, we're going nucleotide by nucleotide or letter by letter to see if there are any changes, but that's not all encompassing of genetic testing, right? That's
Just
one
piece.
approach, right?
Okay. Yeah. So what I see a lot out on the boards when people are talking is like, oh, we went through genetic testing. And I think that they're really thinking of having the tumor tested.
Yeah.
Okay.
Yeah.
And
A lot of times, like, when I meet with someone who's referred to me, we'll talk about genetic testing and they'll say, oh, I already had that. And I'm like, oh, you did? Where? They're like, well, the oncologist told me they were going to do some genetic testing. I'm like, on the tumor, right? Because they do some genetic testing on the tumor because one, it helps define what kind of tumor it is. And two, they use a lot of that information actually also for prognosis. Like, is it a favorable prognosis? Is it a poor prognosis? And there are certain things that in the tumor, when you do the molecular testing or gene testing on the tumor, that tells you what's the best way to treat it? What sort of chemo should we go after this with, chemo and radiation? Though it can be, as you say, very confusing, and sometimes that type of testing, like I said, can give us clues as to the other type of testing, the germline testing, the syndromic or hereditary testing. But what's going on in the tumor is not always what's representative of what's going on in the rest of the body.
Thanks for clarifying that, because I know that as a lay person starting off in this process years ago, it was confusing for me. So I appreciate the fact that you cleared that. Do other members of the panel have some follow-up questions for Joyce? Yes, no? No other questions? Miriam?
My concern was setting up a protocol for testing that would identify some of our unknowns. And I think that your presentation really answered most of my questions, and I'm not sure how that could be done outside of a research setting. So, I mean, I would say to you, how would we identify the genes of the future that we need to know what are the cancer predisposition syndromes? And I think the answer that you gave is research, but maybe you have some other alert clinical observation, whatever.
Yeah, no, I think you're absolutely right. I mean, I think the way in order to find answers to the unexplained, it's most often done in a research setting. So there are investigators around the world who have a passion and a focus on Wilms tumor. And they either collect samples from their patients, or people send them patients to those locations and labs to do research for gene discovery. There's a large effort on the Children's Oncology Group, a special interest group for renal tumors, where they do collect tumors, they do research to try and further our understanding of Wilms tumor and other renal tumors. And that's kind of how we've come to do all the testing that we now do, and come to learn about all the genes and syndromes that we are now able to test for. You know, when I started out, if someone was referred to me for bilateral Wilms, we thought of WT1. And that's pretty much it. And now, like 10 years later, we have so many more things that we think about and test for. So really collecting lots of participating in research when you don't have those answers, that you don't get your explanation, participating in research, donating tissue, donating time to try and drive our medical understanding and gene discovery.
Well, thank you for that. Does anybody else have any questions? We have like 1 minute left before we need to jump off of here. Does anybody else, Erin or Courtney, have any questions?
Yeah, I have a question that might be a bigger discussion, but as a parent with a predisposition, I am concerned about the children who present asynchronously, and that the bilateral doesn't appear right away on diagnosis. And I'm concerned that some of these children go straight into surgery and have that entire kidney removed, and now we have a second mass in the next kidney, and we're putting them in a compromising situation. Do we have ideas on how to get these children to a better spot, or to provide that chemo at first, or the genetic testing first? I believe our 4 masses were a silver lining to making a better decision for his surgery. But how do we get our Wilms tumor community to that spot and give these children a better life outcome, I guess? Which is
Yeah, absolutely. It's a phenomenal question, and you're right. There are multiple answers to that question that could open up a whole big discussion. But it takes into account the need for lots of different things to happen up front, right? It would be helpful to do that germline and somatic testing up front, right? If we're finding a WT1 mutation in the tumor, that individual should be referred to either rule out that it's not in the rest of the body and it's only in the kidney, or they need to, if they do find it, we need to be following them every 3 months very carefully, not only for that particular tumor, but are there other, within a different syndrome, are there other tumors? And different genes have different screening protocols, so we want to make sure that we're implementing them from the get-go. And so it's a multi-pronged, we need the genetics to be on board, we need the pathologists to be on board, we need the oncologists to be on board. So there is a lot of educating that needs to be done to get all of those different types of physicians or doctors up to speed, so that they can refer them to me, so that I can go ahead and do that testing. So I would say a short answer to your question is education, education, education.
Which I'm so grateful that you were able to join us today, because this is a big part about what this group is about. We have a 2-pronged approach happening inside our Elevate work groups. One is to unearth these sort of topics of importance to members of the community. So in this case, the Wilms community, this is a topic that's become incredibly important to our group, and wanting to understand it better so we can be better advocates and get high quality information out to particularly patient advocate and caregivers, but as well the medical community. And I think we've also, really are trying to get involved in these interdisciplinary teams and discussions across the board. We've met with oncologists and scientists, and also you, to better understand, and pathologists, how do these pieces kind of connect and how do we create better educational opportunities for each one of the decision makers along the way, and what ways in which could we contribute to the research? How can we as a nonprofit then financially even support research efforts that might unearth these clues to creating better treatment options and outcomes for kids diagnosed? So I'm incredibly grateful to all of you today. On that note, I just want to say thank you once again to Joyce Turner, as well as all of these other members of this team here, because they're the reason that this conversation really began. So thank you everybody for joining us today. On that note,